Good morning, everyone. My paper goes by the title A Comparative Study of Automated and Manual Objective Refraction with respect to subjective refraction in an age group of 10 to 16 years. Children have stronger accommodation as compared to adults, and accurate refractive error assessment in them can be challenging. Autorefractors are very useful tool in busy clinical schedules, and newer autorefractors claims to overcome accommodation to give accurate results. So, in this study, aims to determine the concordance of refractive error assessed by autorefraction with and without cycloplegia, cycloplegic manual retinoscopy to that of final acceptance by subjective refraction. So, this was a cross-sectional study done in the Department of Ophthalmology in a tertiary care center in children of age 10 to 16 years over a period of 1 year, and the sample size was 58 eyes. So, children of age 10 to 16 years who have not worn glasses previously and with vision less than or equal to 612 and improving to 6/9 or better with pinhole, or children with esthenopic symptoms were included in the study. And children with decreased visual acuity due to causes which are non-refractive were excluded from the study. After taking written informed consent from the guardians, distant visual acuity was assessed using Snellen's chart. Refraction was done with autorefractor and cycloplegia achieved using hometropin, and cycloplegic retinoscopy and cycloplegic autorefraction was assessed. The final acceptance by subjective refraction was done after 3 days. Coming to results, a total of 60 right eyes of 60 patients was used in the study. Following abbreviations will be used in the slides to follow. We had slightly more females as compared to males and far more myopes as compared to hypermetropes. First, on comparing manual retinoscopy to the final acceptance, in spherical errors, both myopes and hypermetropes showed good concordance with between the values obtained by manual retinoscopy and final acceptance. In cylindrical errors also, there was no significant deviation between the manual retinoscopic values and final acceptance value. The derived spherical equivalent value also showed good concordance between manual retinoscopy and final acceptance. Now, on comparing non-cycloplegic autorefraction to the final acceptance, in spherical errors, hypermetropic patients showed significant deviation as non-cycloplegic autorefraction tends to underestimate hypermetropia, whereas in myopes the values obtained were similar. The cylindrical errors values, however, did not show any significant deviation in both myopes and hypermetropes. Spherical equivalent values also showed similar results to the spherical values with significant underestimation of hypermetropia with non-cycloplegic autorefraction. Now, on comparing non-cycloplegic autorefraction to cycloplegic autorefraction, in spherical errors, non-cycloplegic autorefraction tends to underestimate hypermetropia and overestimate myopia, but significant deviation was seen only with hypermetropic patients. Cylindrical errors here also did not show any significant deviations between the two, and spherical equivalent values, same as spherical errors, showed significant deviation in non-cycloplegic autorefraction and in hypermetropes only. To find the closeness of the three objective refraction to the final acceptance, mean deviation from the final acceptance was calculated. Manual retinoscopy showed maximum closeness to the final acceptance. Data analysis revealed that in myopes the deviations were not significant, whereas in hypermetropes, non-cycloplegic autorefraction had significant deviation from cycloplegic autorefraction and final acceptance. Coming to discussions, a study by Anita Ganger done in 100 eyes of patients of age 7 to 14 years studied on cycloplegic autorefraction, cycloplegic manual retinoscopy and subjective refraction found that they did not have any significant deviation from each other. Our study had slightly fewer sample size, and an older patient of age 10 to 16 years also included non-cycloplegic autorefraction and found that there was significant deviation with non-cycloplegic autorefraction as compared to other in hypermetropes only. Another study by Babita V. et al. On comparing cycloplegic retinoscopy to non-cycloplegic autorefraction had less than 0.5 diopter difference between the two in myopes and 1 to 2 diopter difference in hyperops. Our study, however, had the difference of only 0.2 diopters in myopes and 0.5 diopters in hypermetrops. Study by Urasar et al. And Guha et al. Also yielded similar results to our study. So to conclude, cycloplegic retinoscopy remains the gold standard for refraction, and cycloplegic autorefraction is comparable to cycloplegic manual retinoscopy. But non-cycloplegic autorefraction tends to underestimate hypermetropia and overestimate myopia. So I would recommend cycloplegic refraction, whether it be automated or manual, for refraction in children. These are my references, and thank you.
Very nice. What could be the reason for this underestimation of non-cycloplegic and hypermetropia?
Sir, in children, they tend to use their accommodation to overcome this hypermetropic refractive error. And with autorefractors, they seem to get this wrong and give a more myopic value than giving proper hypermetropic values.
Did you do that refraction yourself, or is data collected?
No, sir. Manual retinoscopy I was done by myself only.
Which year you are?
Final year, sir.
You have got ample experience in refraction?
Sir.
Okay, thank you.
MES Medical College, sir. Malappuram. MES Medical College.